Hi, this is Dr. Centeno, and today I'd like to talk to you about failed versus successful percutaneous ACL repair, or Perc-ACLR. This is a procedure that we pioneered and invented, and have a lot of experience in the differences between doing this right and doing this wrong. And like any inventor of a new procedure, what we don't want to see is that this procedure gets out there in the hands of doctors who aren't trained how to do it. It fails. And as a result of that, word gets around that the procedure doesn't work, when in fact the procedure is highly successful if you know how to do it. So this is a tale of two patients, both teenage females who injured their ACLs during sports. One healed well with excellent firm Lockmans and is returning to sports. The other didn't heal well and still has a lax Lockmans and is not yet back to sports. So the question is why? And I think it's due to two big issues. In fact, these are both two new patients that we got MRIs back on just this week. And again, it's a great teaching point that I want to make sure I drive home here. So patient one, first issue was the doctor that did it didn't know how to do a proper double bundle injection. That means two different spots at the insertion and two different spots at the origin of the ACL, so that both ends of both the anterior medial and posterior lateral bundle are covered. So as you can see here, two images here because this is the best this ACL actually looks. So you can see here the ACL on before, it's just this ghost-like appearance, mucoid blown out. Whereas in here, we're not quite sure what's happened here. It looks like there was a piece of the ACL that tried to heal here. There's another piece that's coming down this way. It's really not a successful treatment result. And this is a few months after injection. This patient still has not returned to sports. Now look at this one. This one did have a double bundle injection. In fact, I did this one out in our Las Vegas clinic. And you can see that while this ACL looks slightly better before, it's pretty much in the same ballpark when it comes to just looking at it visually as the other one, but a dramatically different result here. And the reason I'm showing you the the proton density films on these is that regrettably the T28 images were taken with vastly different parameters. So this is the best apples to apples comparison. The other big difference between these two patients was this measurement. And that's what I call the posterior tibial offset. Others have other names for this. But the bottom line is you can tell just from looking at this patient who failed and this patient over here who was a success, that if you look at the amount the femur is posterior to the tibia on both of these, this one over here is far more posterior. In fact, when you measure it, it comes out to 11 millimeters back, whereas this one's about 5 to 6 millimeters back. Now, 5 to 6 millimeters is something that's achievable with this technique. 11 millimeters is generally not something that's achievable with this technique. And to learn more about this measurement and why it's important and how to pick these patients, as well as how to do this procedure, please don't try this at home, kids, meaning that don't just stick needles in the knee and call it good. Please take the IOF course. This is a nonprofit course. I'm not making any money off of it. No one else is either. So take this course, learn how to do this procedure properly, number one, and then number two, learn the finer points of how to pick an appropriate candidate versus an inappropriate candidate for this groundbreaking procedure. This procedure is a game changer. Trust me when I say that 20 years from now, we're going to look back and laugh that we used to rip out ACLs that were torn and install surgically a replacement. That's how good this procedure works if you know how to do it well and if you know how to choose the right candidates. So thank you so much for watching and have a great day.